Hi, it's David Liew from Melbourne, Australia, and I'm back reporting from Vienna for Eular 2024. And the meeting's kicked off, had our first abstract session, and I want to talk to you a little bit about rheumatoid arthritis therapeutic strategies and converting what's a biologically plausible promise into actual results. So, especially in seropositive rheumatoid arthritis, there's an idea that I guess we've got a better idea as to what's going on, and that plausibly we can interrupt what we think is a likely process behind that, especially when we know what we know about the shared epitope, and we know what we know about co-stimulation and the role it has in the beta cell T cell interaction, and we know that we have an agent that can interrupt the co-stimulation in the form of a betacept. So it's a promising idea that we can try and hit with the right sequence of therapies to try and turn off RA and really induce a tolerogenic state. Unfortunately, sometimes things seem good in theory, but aren't always perfect in practice. And so we saw two studies in the abstract session which tried to take advantage of what I've just told you, but unfortunately didn't really show the results we would have liked. The first one's the amplified study, which looked at early rheumatoid arthritis, rheumatoid factor ACPA positive, and gave abatacept versus adalimumab. And the idea is that there's been some promise shown from abatacept in this type of population. Could it outperform adalimumab? You can already tell by the way I'm setting this up that, in fact, that's not what happened. In fact, what we saw was that abatacept and adalimumab performed exactly the same over the overall cohort. And now abatacept did slightly better in the high ACPA positive patients, and adalimumab did slightly better in the others. But, the shared epitope didn't seem to stratify this, and it's really disappointing that we thought we might have some form of biomarker in the form of ACPA positivity or the shared epitope that might help predict who would respond to abatacept. And yes, maybe a really high ACPA positive titer might do that, although that's not yet entirely proven. What we do know is that this study really did not show any difference between abatacept and adalimumab, and that's a bit disappointing. Another study along these lines, much smaller study, but from the Erlangen group, so the Department of Georg Schett in Germany, looked at the idea that maybe you could try and induce a tolerogenic reset by giving rituximab and inhibiting B cells, and then after that, hitting the patients with abatacept. So they looked also at ACPA positive rheumatoid arthritis and tried to do the B cell T cell 1-2 combination. And they looked at 20 patients and they compared that 1-2 combination with just straight rituximab. Small numbers, but they really didn't see any difference in disease activity either, even though it seems like the idea that kind of might work. Unfortunately, it was a bit of a swing and a miss. These studies are still useful. We know that maybe that kind of approach might work in other diseases, and we saw the safety of the rituximab and abatacept to follow idea, essentially giving two biologics, and it seemed to work to be quite safe from that point of view, but it certainly didn't lead to advantage in rheumatoid arthritis. Nevertheless, you've got to applaud this, and it's back to the drawing board. So we try more to try and find something that's better than our current therapies in rheumatoid arthritis. For plenty more on RA and everything else at this meeting, where head on down to rheumnow.com.